Good morning, Walter.
Oh, good morning.
So we will be beginning in just a few moments. We're going to let people enter the meeting, and then we will kick off our presentations. Thank you for your patience. Good morning, everyone. We're still letting a few more participants in, or expecting a few more. So thank you for your patience, and we'll kick it off as soon as possible. Look forward to the discussion shortly.
Courtney, if you want to go ahead, I think the numbers are all in now.
Excellent. Well, good morning, good afternoon. Thank you all for joining our session here today. We are excited to have several speakers talk to you this morning or today around the economic impact model that is under development as part of a USAID Act to End NTDs West project. This economic impact model is underway in development. Slight delays given the current situation we are all in, but it's focusing on LF. So we are actually very fortunate that the model is not quite done because we are able to share with you all today the progress we have made, the work that has been accomplished so far, and where we're headed next, and look forward to a rich discussion to hear your all's feedback, clarifications, and ideas if you can share further with us. We have 3 speakers here today that will go in order, and then we will open up the line for a full presentation where we will be moderating the chat feature as well. So if there are any questions, please feel free to either wait until we open up the discussion or go ahead and put them in the chat, and we will sort through them as soon as we are through each of the presentations today. My name is Courtney Johnson. I am with Deloitte and the project manager for this project for the Deloitte team. I'm here with some of my colleagues from some of our consortium partners, as well as with Deloitte, and we'll be passing it off shortly. I did want to say to everyone who is participating that the conversations in this discussion will be recorded here today. So for your awareness, we look forward now to diving into the slides. So with that, I'm going to flip ahead and pass off the discussion to my colleague, Anna Maria, to introduce herself and start by giving a bit of an overview of this model for everyone here today. So thank you, Anna Maria. Please go ahead.
Thanks, Courtney, and welcome all. We're very excited to have this conversation with you. As Courtney mentioned, I'm Anna Maria Shaker. I am a manager at Deloitte, and I support USAID and other international donors who advance economic growth and sustainability. So my experience is in the Middle East, North Africa, as well as West Africa and East Africa, and I'm supporting our USAID Act to End NTDs West project. And I specialize in impact analysis, performance management, and how do we use data to drive process optimization. I have a master's in foreign service from Georgetown. Courtney, next. So I'll speak a little as an overview of the model, and then my colleagues will go deeper into what we're talking through today. So as an overview, the economic impact model itself aims to estimate the direct and indirect economic benefits and impacts and efficiencies and social, societal benefits by investing in NTD programs and NTD interventions. And the purpose of the model is to support NTD programs to develop investment cases that they can then use to advocate for domestic resources and prioritizing NTDs in a multi-disease environment. We'll be using a use case of LF, as Courtney mentioned, and we'll be using it in testing it out in Sierra Leone. So with the support of Helen Keller and Deloitte, the Sierra Leone NTD program will be piloting the tools, and they have been serving as our advisor on country needs and on their program and financial data that we've been using to test out the tool. And they'll be testing the tool when we are ready to pilot it and utilizing its outputs for advocacy, and we'll be able to refine it with our colleagues in the NTD program in Sierra Leone. For a future use, we will be refining the tool based on the pilot in Sierra Leone. And then we'll be able to make this more widely available to the countries we support in Act to End NTDs West so that they can create investment cases to enhance their advocacy efforts for domestic resources within their countries. So I'll go deeper into each of these. So why an economic model to begin with? Well, we've seen that national NTD programs have made significant progress, including the declines in the burden of NTDs, specifically PCT NTDs, so LF, onchocerciasis, schistosomiasis, trachoma, and STH. And this has been with considerable support from external partners. And we've seen that many affected countries have really substantially reduced the NTD prevalence and the disease burden. So these gains have really created wonderful opportunities, but have also created challenges. And one thing that we've seen is that the gains have created requests from donors to have greater local ownership so that in the future, when countries have reached elimination and control targets, governments can own this and drive this and maintain and sustain their elimination and control states. But there is a fear that governments may revert to continuing to neglect these diseases, so that would lead to the reemergence. So to ensure that countries are pursuing a greater proportion of financing locally, NTD programs are requiring tools so that they can understand the benefits of investing in NTDs, and they can advocate and make investment cases for domestic resources as donor contributions begin to wane. Further, these tools are very important to make the case of prioritizing NTDs in a multi-disease environment, and which NTDs you might prioritize. Next. So within the context of Act to End NTDs West, we are supporting, as part of the project, our NTD programs to build their capacity of their governments and other domestic stakeholders to sustainably implement effective NTD programming that responds to the shifting needs and demographic context, and that's resilient to decreasing donor support. And so that's the context in which we are working on sustainability. And so these tools will help the NTD programs to sustain their impact of their investments and transition to vertical activities to the mainstream and to mainstream within the health sector systems. As part of sustainability, that really implies that you're mobilizing domestic resources to the extent that is possible to finance the core activities of an NTD program, such as deworming, surveillance, and morbidity management. So we've seen that many disease programs have deployed investment case studies to support health financing decisions and domestic resource mobilization, but there are no known tools available to assist countries to estimate the economic impact of NTD interventions specifically. So that's where the economic impact model seeks to support and to fill that gap. Overall, this tool and our work supporting NTD programs around sustainability supports a main outcome of the country mobilizing domestic funding to support NTD program needs. Next. So the tool for integrated planning and costing, or TIPAC, is a costing tool that NTD programs currently use to understand their funding availability and identify their funding gaps so that they can better advocate for filling those funding gaps, and they can really highlight the target areas for improved resource allocation. So TIPAC is a very comprehensive tool with several functions, and we noticed as we were developing the economic impact model that there's a lot of overlapping data required for the TIPAC and the economic impact model, especially the costing aspect. And so what we've done is we've sought to really reduce the burden of data entry on an NTD program user into TIPAC and the economic impact model. So the economic impact model will actually pull from the TIPAC, and the TIPAC data will automatically populate within the model, and we'll be able to add a few other data points that will be needed. But this is really to reduce the burden of data entry on the NTD program user and use the data that they're collecting in multiple ways. And the TIPAC and the economic impact model moving forward will be two data-driven tools that NTD programs can use to advocate for increased domestic resources. Next. So a little bit about the Sierra Leone pilot. Sierra Leone is targeting elimination for LF and onchocerciasis in the near future, and they're going to be serving as the pilot for the development of these tools. And we work with and we support the Sierra Leone NTD program in the Ministry of Health and Sanitation as part of Act End NTDs West. And their government and the Sierra Leonean government has been responsive and receptive thus far to economic impact cases being made as a part of domestic resource mobilization advocacy. And so we thought that this might be a very good country to engage on this pilot. So with the pilot, they will be using the tools to, as I've said, they're providing a lot of the advising on country needs, but they'll then use the tool to estimate their direct and indirect economic benefits of averted NTD cases and investments in NTDs, and they will be pulling the data sources from the TIPAC that they've been completing annually, and we just wrapped up a completion virtually, and other epidemiological data that they have available in Sierra Leone, and program level data related to the stage of MDA by district, as well as national data available within the Bureau of Statistics. They'll then test this tool out, and be able to develop advocacy cases based on advocacy messaging based on investment cases. Next. So we are collaborating the USAID Act End NTDs West project with the USAID Centers for Disease Control and Prevention's Division of Parasitic Diseases and Malaria, and we have one of our colleagues from the CDC here today. And we are, we've each kind of focused in on a specific part of the model and to support its development and its piloting and overall rollout in Act to End countries. So just to give you a kind of a sense of who does what, the CDC is our lead developer of the models and of the model, and then the how it's translated into a tool for each disease. So right now we're working on LF, and they're the advisor on health economics and NTD epidemiology. Deloitte Consulting, we have been the advisor on health financing, economic modeling, and usability. And we have been helping with the provision and interpretation of NTD program cost data, since we support countries in Act End West with the TIPAC. And we will be providing technical assistance to Act End West countries as they implement this tool. Helen Keller International, who we also have joining us. They are the advisor on NTD field operations in Sierra Leone. They have extensive country knowledge and have been providing and helping with the program data as well as NTD epidemiology within Sierra Leone. And they've been our main liaison with the Sierra Leonean NTD program in the Ministry of Health and Sanitation. And finally, the Sierra Leone Ministry of Health and Sanitation NTD program themselves have been an advisor for their needs, the country needs, the program needs. They've been providing financial and program data. And as we pilot it, they will be doing the user testing and utilizing the tools, tool outputs for advocacy and resource mobilization. Next. So a key, what's next when we think about this after we've developed it? The key output will be one Excel-based tool that will have the diseases in the tool. And right now we're just building out LF. The current prioritization of the tool will be LF, then onchocerciasis, then STH, and then schistosomiasis. And we'll also be developing a user manual so that NTD programs can use this independently moving forward. And then we've submitted this to the ASTMH symposium, and we plan on publishing about the outcomes of this. But as I mentioned, the key outcome here is that countries are able to utilize evidence to advocate for mobilization of domestic resources to support NTD programming. And with that, I will actually hand it over to my colleague, Walter.
Thanks, Anna Maria. Next slide. My name is Walter Cheng. I'm a health economist at CDC, the Center for Global Health, where I support pretty much all the NTD work that we're doing there for the malaria branch and other things, including drones and virtual reality. For this work, we've been working with the Division of Parasitic Diseases and with HK and Deloitte over the last 6-7 months to come up with the tool that Anna Maria has really done a good job explaining. I just want to take you through a few aspects of the tool, and hopefully we'll get some good feedback from you as we go forward. And just issue the standard CDC disclaimer that this, what we're saying here, is not the official position of CDC or the US government. Next slide. So as Anna Maria mentioned, the focus of this tool is to really help people at different levels of government, either the district level, in some countries at provincial level, or at the national level, to make an investment case for NTDs. So it's not really geared towards economists, but more like non-economists, like the DMOH, the DHMTs, at that level, to really fine-tune different parameters so that when they make an investment case, they've covered like their bases. But to do that, we focus more on simplicity of inputs and of use. And that means we try to really minimize what I call like search costs for tool development. That is, minimize like literature searches in terms of like utilities, or minimize literature searches in terms of various costing aspects or like discounting rates or parameters, so that the user doesn't have to be trained in health economics to really use a tool to make such cases. And so we really try to leverage existing data resources like national census data, the TIPAC that Anna Maria talked about, that most users have easy access to, and minimized some inputs like utilities that you may need to go into, like the global burden of disease, or do some advanced searches to put into the tool. And I'm going to show some of these inputs in the next couple of slides. So we pre-selected some of the more technical bits and put them inside the tool already. But any advanced user can go into the back end and really change. So for example, if we said like for hydrocele, your quality adjusted life years or like your utilities for hydrocele is like X%, we fix that. But if you felt like the literature has really changed over time, then you could go into the back end and modify something like that. But being an investment case-oriented tool, we focus more on outputs that can be used to tailor arguments at different levels of government. So for example, at the Ministry of Health level, someone can go into the tool and change like the perspective into more of a health sector perspective. And then get outputs like clinician time saved, which can also translate to like the number of staff hours saved or the number of like nurses that can be reallocated into other roles based on like a reduced disease burden. Number of cases averted, or QALYs or DALYs. But at the Ministry of Finance level, you go into the tool and change now the perspective, more of a societal government level perspective. And then you can get the more interesting things that can appeal to a finance guy, like labor productivity changes, work days lost, school hours, saved, effects on private consumption or informal care costs. So the user will be able, just by using like a drop-down menu to really change different perspectives. And then you get the outputs that you can use to appeal, let's say, to your local member of parliament, or to appeal to the permanent secretary at the Ministry of Health to lobby for funds. And we feel like this kind of like fine control will really help like target the messaging to relevant audiences rather than like a blunt tool where you go and talk about QALYs to someone who doesn't really, who can't really translate what QALYs is into like everyday budgetary needs. So just to reiterate that this tool is really geared towards non-economists, but at the back end, you can go in and like modify some of these parameters. Next slide. So this is like a screenshot of like an example entry or input page where you will go in there and, for example, change like the exchange rate if you want to convert like the values from the local currency into like US dollars. You insert like GDP per capita and discount rates. And these sources, these data inputs are readily available either from finance or like from the newspapers. And then you also put in like the unit level population based on age sets. You can get this from the census data or like from the National Bureau of Statistics, or like from spectrum files. I know this may be a bit of a challenge in some countries if the census, took place like 7, 8, 9 years ago. And so you have to like really work closely like with the relevant offices, whether it's the national bureaus or other agencies to get this data. More so like if your focus is more at a disaggregated level, let's say at the district or sub-district. And at national level, there are always different sources you can get. You can go to like UNICEF or UNFPA and get this data. And so this particular level, I think, will be the hardest bit for people to fill in terms of the tool. So the other aspects, I think, are fairly straightforward. Next slide. This is our draft user interface. And so just to go over what I was talking on before, you can go and change the model type. So in case your focus is to give like some uncertainty estimates around the values that you get, you have a drop-down menu where you can change the model type and say, I'm looking at over probabilistic kind of analysis or a deterministic one. And then since we also plan to like transition this tool to bring in like other diseases, we have like a menu where you choose like the starting age for the disease impact. So something like in STH, your focus is more on like school-going age and above, while for LF, you may be thinking about like older populations. So we give you the opportunity to go into the tool to really like calibrate like your impact on particular population segments. And even for LF, let's say you're only interested like in people, what's the impact of this change in the financing on people, let's say, who are like 40 and above, then you can restrict like that start age to like 40 years and above. Or you can drop it and see how that changes. We're also giving like the user the opportunity like to also think about like the time horizon of like the impact of various changes. So you can say like, I'm looking at the impact of these funding changes like in the next 5 years or 10 years or over a lifetime. And then I mentioned like the perspective where you can say, okay, my focus right now of these outputs is going to be on the health sector. And so you change that perspective, or it's going to be at the level of government or society, then you change the perspective. And then to the top right, we put like a slide about where you can change the funding percentage. So like 100 means like status quo. And then if you go down to 0, it means like there's no funding at all for NTD programs. And or you push it the other side up to like 200, which means like it's essentially double the funding. And then just below that, we have like different parameters where you can say, okay, the initial prevalence that we have for, let's say like LF is 3% or 5% or 10. And our target prevalence will be like, let's say like 2% or 1%, depending on the country needs or the disease. So you change that, and then you also change like the focus elimination date. So we say, okay, perhaps our target is to reduce or eliminate this disease by 2026 or 2030. And then automatically the model like calculates for you the different costs and also shows you if your assumptions can really be met by that target date. So if you say, okay, I've reduced my funding by like 50%, but I still want to eliminate or eradicate disease X by 2026, then you can say, okay, based on this assumption, this is not going to be possible. And then on the bottom left, we have like some of the outputs that you can get from the model, and they're both discounted and non-discounted. So you can get things like clinical man hours, you know, under different like assumptions, like you're going to avert or save, out-of-pocket costs, you know, like lost labor days, and the total economic cost. And the total economic costs have included things like, you know, the value of lost productivity, private consumption, premature life loss depending on the disease, cost of informal care, and those have been brought in there. If you went into the back end, you can actually find like the separate calculations. We just put these as pretty much like as a placeholder right now. Next slide. So this is a screenshot of like one of the back ends. So where we have like, you know, different utilities that we've already put in for the end user. But if you're an advanced user, you can really come in here and change. And you can notice that depending on the model type you've chosen, it can either be probabilistic or deterministic. And you can go in and say, okay, I kind of disagree with like this guy saying that the particular distribution was like gamma or beta, and I'm going to change it to something else like log normal. And you have that opportunity to change some of these parameters on your own and also fine tune the tool to meet like your own needs. We also have like some of the things that we put in, like, you know, like ADL episodes, for example, are based on like current literature. And if you feel like in your country or in your setups, you may need a bit more fine tuning, then you just come in here and change them. And we're gonna put up like a user manual that will also help any user, either basic user and advanced user, like really play around with the tool, recalibrate it and make it like a stronger tool for their purposes. Next slide. And then this is like an additional screenshot of a backend that shows how like the model just picks up like different edge cohorts, you know, recalibrates like probabilities, and performs like some of the simulations that I've mentioned. Next slide, which I think should be my last. Yeah, and some of the literature sources that we use in developing like the tool. Thank you very much, and I'm available to answer any questions that you may have. Mary.
Thank you, Walter. As Walter said, I am Mary Hodges, the country director for Helen Keller International in Sierra Leone. I've been there since 2008. when USAID funding for the Integrated NTD program commenced. I come from a background in pediatrics with a doctorate in parasitology from Glasgow University and many years of experience in nutrition and public health. I love working for Helen Keller as it specializes in evidence-based programming and bringing those programs to scale within existing government and civil society platforms. Next slide. Thank you. So the background to Sierra Leone, as already stipulated, we have 4 NTD programs, 4 NTD diseases, onco and LF, which are targeted for elimination by around 2025, and schisto and STH, which are targeted for control. And we've been making substantial progress towards both of these goals. In the last 12 years, over the last 12 years, we have been able to stop LFMDA in 9 of our 14 endemic districts, and 8 of these districts have already passed their second transmission assessment survey. Over the last 10 years, ophthalmologists have repeatedly told us that they're not seeing new cases of blindness due to onchocerciasis. Obviously, old cases still exist, but no new cases of blindness from onco are being reported. In 2016, a national survey demonstrated we had reached control levels for STH. In addition, there have been substantial reductions in prevalence and intensity of schisto infections in the 7 districts where MDA with praziquantel had been justified. Since the integrated program began, district-level epidemiological coverage thresholds for onco and LF have been over 65%, and programmatic coverage thresholds of over 75% for schisto and STH have been regularly achieved. For example, in 2019, the NTD coverage data was significantly above thresholds for these diseases. Next. So the economic impact model, the proposed tools will be used by Sierra Leone and other countries to estimate how their interventions, such as MDA and morbidity management, will positively impact the population and efficiencies of the health and other sectors. Variables under consideration include school attendance, performance, achievement, workforce participation, wage earning capacity, the health sector resource efficiencies, gross domestic product, and income tax base. The Act West will support turning the TIPAC data and the results from the economic impact model into information that can be used for advocacy. Since financial and operational sustainability are key priorities for both the national program and the donors, further capacity building support will be ongoing. Parliamentarians have demonstrated a willingness to allocate government finances to NTDs, but the cost-benefit case must be clear to them in order to compete with other priorities such as maternal and child health, malaria, HIV/AIDS, and of course epidemics. Depending on the audience, the NTDB will package results for advocacy for key goals such as budget lines. Progress has already been made with this approach by producing a cost-benefit analysis for LF hydrocele surgery, which was presented to the senior management team of the Ministry of Health last year. The data was well presented, well received, well understood, and is now under consideration for further funding. Next slide. As we heard on Tuesday at the plenary, we have to remember the human story. And this is an example of that human story. The model itself aims to use economic, demographic, and epidemiological data to tell this story. and it aims to show the impact on people and communities and the financial incentives for investing in NTDs to government officials. This lady, Hannah, started experiencing recurrent pains, swelling and fevers in 2003. These episodes continued and her left leg became increasingly heavy until she was unable to continue salaried work as an ancillary staff in the local hospital. She spent all her disposable income on doctors, medicines, and traditional healers until there was no more money left and no progress had been observed. In 2011, she participated in MDA for the first time during its second round in the capital, Freetown, and subsequently commenced morbidity management. Her condition gradually improved with the absence of acute episodes and the gradual reduction of swellings. Over 6 to 7 years, her right leg returned to what looked like normal, and her left leg to approximately 2/3 of its previous size and weight. She was able to contribute towards simple domestic tasks and caring for her grandchildren so that her daughter could participate in income generation activities. She became a willing advocate for the NTD program, participating in social mobilization on radio, encouraging other LF sufferers to participate in MDA and take their ivermectin and albendazole annually. Hannah once said, "I don't let my condition press heavily on my heart. It can be painful, frustrating, and depressing. You can't wear shoes. It's hard to walk. But if you allow yourself to feel depressed, you will die very quickly." The economic and societal impact of LF in a low-income country such as Sierra Leone is hard to quantify, when the neglected populations represent the lowest wealth quintile. But the current model is a start upon which we hope to build a robust argument for domestic funding, for sustainability, once elimination and control goals have been met. Next. I know Hannah and all the other LF sufferers in Sierra Leone and around the world would like to thank the donors for their generous support and the ministries of health and the many thousands of community drug distributors who make this program possible. Thank you.
Thank you, Mary. Thank you, Walter. Thank you, Anna Maria, for those wonderful presentations. We now have the remaining time to open up to your questions, to your feedback, and for hopefully a really strong discussion about what can be done with this model to make it even stronger. I would like to first give the opportunity to Justin, who is the project manager for the Act to End NTDs West through FHI, and leading our health systems strengthening work, particularly around sustainability, to see if he has any words just to frame the discussion ahead of time. Justin, not to put you on the spot, but is there anything you would like to share as part of this project's goals, or anything you heard today that you would like for the audience to make sure that they're aware of?
Oh, thank you, Courtney, for opening the microphone and to me. And I'm just introducing myself. I'm Justin Tin. I'm health semester lead.
Justin, sorry, can you just put your microphone a little closer to your mouth, please? Adjust your microphone. Thank you.
Okay, so I'm telling that I'm Justin Tin, health semester lead for the USAID-funded program Act West. Covering 11 countries in West Africa and one in Central Africa. And grateful thanks to the team, Courtney and Sierra Leone team, CDC also involved on this, that is supporting what also we consider in this program as critical. And we are seeing that also some of the partners also are trying also to push this agenda forward with regard to sustainability. For ActWest, this sustainability piece is very important because we are targeting long-term sustainable service delivery, providing support to country team to ensure that national health system has the capacity and the commitment to make the provision of NTD available at every level, and also to ensure that progression to elimination and control also is moving forward, and government is contributing. Contributing is not just only on a financial point of view, but also the opportunity to leverage existing platform at community level, existing platform within the health system itself. So this is a key point when we look at tools and how also to help the NTD team and the MOH bring different stakeholders around NTDs. We have been working since last project, which was End in Africa funded by USAID, trying to find how to get more attention from government, and how to build the case to government became at that moment issue. This has been the first step of this conversation between ActWest and the CDC, trying to find a way to make the case to government health entity also have argument for government to pay more attention to NTD, because this is that is creating disturbing also economic productivity, disturbing also well-being, and sometimes also not well known by government. So the economic impact model for this program is a key tool that will be supporting advocacy, but advocacy in terms of providing the rationale and an objective rationale on how and why to invest in NTDs, looking to different perspectives and different audience. So we welcome any contribution and questions that can help also the team to make the tool strong, and looking also to any experience that emerge from different countries also that could be input for this tool that at the end could be useful for the entire community. So thank you, Courtney, for providing me this space to share our perspective in terms of ActWest sustainability approach, and how also bringing different stakeholders from different ministries, from private sectors, from civil society organization around NTD at country level to support and put effort together to help the NTD go beyond the elimination goals, but have a sustainable program that can maintain the gain when they will reach also elimination or control of these diseases. Thank you. And we welcome any question also related to ActWest involvement on advocacy and cross-sector coordination, bringing stakeholders together, and how also we intend to use this tool to help the community also move forward with the elimination and control of NTDs. Thank you.
Thank you very much, Justin. I very much appreciate that overview. I'm going to now go through first the Zoom chat, excuse me, and see if I can help direct some of the answers to your questions. I'm going to start with a fairly technical one from Ashil, asking, could the tool integrate post-MDA and surveillance projections for LLF? I will first ask Walter to see if there's been any technical discussion around that, if that's something from a building of the model that could be included. And then Mary, if there's anything that you have to offer around, is this something that you see discussed in country that would be of use, or if there's anything else you would like to add on that topic. So first to Walter, if you wouldn't mind answering the beginning of Ashil's question.
So the question is, can the tool be used to bring in like post-MDA surveillance to cover that?
Yes, to integrate post-MDA surveillance and projections for LF as well.
So we have covered like post-MDA costs. So that's already in the tool. So in terms of like projections for like disease projections, that is partly covered. The challenge is that we cannot fix that into like 2 years post-MDA. So we can try and work on that, but that's a very good point. But that of course, like that's already in there. The post-MDA surveillance costs, that's already in there.
Fantastic. Well, thank you. And then Mary, can you please add on to that as well?
Yes, I think really that was our starting point. We recognized that when we got to the goals, the donor goals of elimination and control, there was a real need to be able to explain to governments the economic benefit of sustaining those goals, which means what is the cost of, for example, LF surveillance, and what is the benefit of maintaining and preventing recrudescence of LF in a country such as Sierra Leone. I think that was really our starting point of how can we quantify the cost benefit of sustaining control and elimination so that governments can think about it and put it in the mix of other priorities that they have to fund.
And then, Courtney, just to add on to that, that's in the tool, we also have like those horizons that someone can change. So you can talk about like what's going to happen like 10 years or 15 years down the line.
Mm-hmm.
Thanks.
Exactly, the time horizon there is important as well. So I'm going to also get through some of the more technical questions, and then there's some broader questions about the tool as well. This next one is from Deborah McFarland, thanking for the good work and noting that with the integration of NTDs into primary healthcare and universal healthcare or universal health coverage, as the goal for many countries, does this tool look at joint costs and benefits? Are there other investment analyses for non-NTD diseases being conducted? And if so, are those data and approach similar? And are the findings being shared? So I think Walter, again, I think we'll do the same order, Walter, and then to Mary, if there is anything you'd like to be able to respond to on that question.
That's a very, very good question. And it's something like we really grappled with. And not even beyond other diseases, even just the issue of like, how do we like look at connected programs? So let's say like malaria and NTDs, where you have like all these mutually beneficial investments. So vector control for malaria also works on NTDs and vice versa. It was really hard for us like to expand the tool in multiple directions. And so we kind of limited it in a way that could make it like not too heavy and not too complicated, but it's a very, very valid point. And unfortunately, we need to look at the other aspect of like UHC and those aspects. Sorry. Mary.
Yeah, I think it's still a work in progress. As we said from the beginning, there's a lot of data, a lot of numbers to be crunched, and a lot of assumptions to be made. And of course, the impact of COVID-19 meant that we couldn't have the sort of workspace that we wanted to have together at national level with the CDC and Deloitte visiting Sierra Leone and sitting together with the other program managers to really crunch out all the other inputs and outputs that we really wanted to understand. So bear with us, this is a work in progress.
Yes, thank you. So one more technical question and then I'll break it up to the broader. This is from Jackie Lane, acknowledging the need for this sort of tool for advocacy and domestic resources. But she's asking specifically about, does the model calculate disability adjusted life years? Can the team share a bit about how they dealt with some of the concerns around using DALYs for NTDs? For example, concerns around disability weights. So I know, Walter, we've discussed looking at qualities and other ways in which to share the results. So can you speak specifically to this question?
So around the use of like DALIs and qualis?
Yes, and specifically the concerns around disability weights is noted here.
So our focus was to really shift the tool more from the more technical issues, let's say about even like the nuances of modeling, into more of a tool that gives, as I said at the outset, an economist some ready output that you can use to negotiate for funds. So at the district level user, these are very important points, but their focus will be more of like, how do I convince the PS to give us more money or to sustain the funding? So, and how do I translate this information into like ready to use daily language? So like one of the outputs, for example, just to give an example, is like the number of staff hours that you're going to save. At a Ministry of Affairs level, that's like a very attractive output where I can say that, okay, if you invested in this, in 10 years time, we're gonna save like 10 or 20 nurse positions that can be reallocated into other lines. And so that's where we're coming in from. We don't really want to like make it like an overly complicated like modeling tool that will be used like to produce like, papers and stuff like that. Our primary principle is we want a tool that's really ready to use by non-technical people that they can use for lobbying. So I know that all these issues around like DALIs, qualis, all the utility weights, and that's why we're also giving like the end user the opportunity to really just go into the back end of the tool. Like that slide I showed with various parameters, where you can just recalibrate those utility weights into like what you think makes sense, and also to give you like the opportunity like to have like sensitive analysis around those things. Like you model and you do like, you can run simulations to get like the range of uncertainty around some of the values that we already have. But the current focus really is more on like a regular end user, your DHMT, the national program manager, just to go and say, okay, look at this model. We've reduced our funding. If we reduce our funding by 50%, then this is what's going to happen to our goals. And as Mary said, like, is there going to be any recrudescence of new infections and stuff like that? I don't know. Over to you, Mary.
As I said, I think you've expressed what we're trying to achieve in both DALIs and qualis. And we're only tackling at present the one disease, LF. And of course, we're going to have to move on to onco and then schisto and STH. Whilst working on this, I think the difference between getting governments to mobilize funding for example, maternal or child health, or mobilize funding for malaria or HIV/AIDS, it's easier for governments to mobilize funding when they can see a real impact on mortality. And I think what we're talking about with NTDs is the impact on morbidity and the shortening of working life and the lessening of the quality of life. So I think that is really central to the impact. The economic impact model is we're measuring morbidity to a lesser extent than we're measuring and quantifying mortality. And that's, I think, where the economists and the permanent secretaries have had difficulty in understanding what the technical people have been talking about all these years.
Thank you, Mary. And that's actually a great way to shift to some of the broader questions that are coming through the chat. And so starting, I guess, with Anna Maria and then Mary, I know you'll have a great perspective on this, but can you speak to, one, the plan that Mary hinted at around that this tool right now is focused on LF, but what are the plans to look at some of the other NTDs? And then thinking about, again, broadening the model, what are some of the thoughts around using this model in other country contexts? outside of Sierra Leone. So Anna Maria, if you wouldn't mind starting with some of the response, and then Mary, if you can add on afterwards. Thank you.
Sure. So as we mentioned, we are starting with LF right now, and we'll be piloting that with Sierra Leone. And the plan is once we've kind of finalized what that first disease tool looks like, so the LF tool, then we're going to expand the tool to include onchocerciasis, schistosomiasis, and STH. And we are currently building the tool such that it will be fairly easy for a user to, in the future, go in and potentially have a drop-down menu that they can go in and select which disease they want to focus on. But that will require building out the assumptions for each of these, the assumptions and data entry components for each of these diseases separately. So right now, we're using LF as the test case. And after we've refined it, then we'll be able to take the LF tool and use that as a model for other diseases that we will be then developing. And so the development of those other diseases will be fairly, easier relative to what the initial LF development was. So we'll do LF, then onchocerciasis, then schistosomiasis, then STH. As far as what this looks like in other countries, we will be piloting in Sierra Leone and then refining the tool itself, the LF tool, and beginning development on the other diseases. But as we finalize the LF tool, then we'll make it available to other countries who we support in the Act to End NTDs West project. And then, beyond that, we will discuss kind of how this gets rolled out elsewhere. Mary, if you want to add anything.
Yes, I think it's important to realize that there are many assumptions that have been built into the model, and every country will have to sit and decide on its own set of assumptions. And that takes time, and it's not something that the CDC can do alone. It has to be really done with the programs in the countries to work out what those assumptions are and agree on those assumptions. That is, I think, one of the most difficult parts of building this. There's a lot of data out there, but a lot of these people are not being recognized. They are the lowest wealth quintile. They don't have a formal income that you can start to really say this is going to be their economic benefit and this is going to be the gross domestic product benefit for the nation. There's a lot of things that have to be generally agreed amongst the country experts as well as the international experts. And of course, each of the 4 diseases that you've mentioned are very different diseases with very different sets of assumptions. So each one has to be taken separately and the case for each built separately.
Yes, thank you, Mary, and excellent points. Walter, is there anything you would like to add around the scaling or additions to this model, or just what Mary spoke to specifically around how this is really built right now for Sierra Leone, given discussions with the program so that it can really answer the country context specific questions for LF there? Okay.
Sorry.
Go ahead, Walter.
Could you scroll back up to my second slide?
Sure.
Yeah. Yeah. So one up. Yeah, right there. So the plan is like we're making the tool into a more portable kind of tool where you could go in and like change these parameters based on your admin level and your country. And that's why we've opened like more for simplicity and remove like the more technical aspects out of the tool. So let's say, for example, like you're at a district level in Sierra Leone. What you really need to look for is more like that district level population by age set, like 0 to 4, 5 to 9, etc. from like the census data, and then insert that here. The other things like, like GDP per capita are fairly standard across the country, or like, discount rates or like the exchange rate, that's like fairly standard. And then next slide. Courtney, yeah. And then on this interface is where I think the other question that the guys are asking, like, we are gonna add like another tab that will allow the user now to have like a drop-down menu where you can change and say, okay, now I'm not interested in LF, I'm more interested like in onco, or I'm more interested like in trachoma or anything else. And then at the back end, those parameters are just going to change automatically. So what we are going to add, next slide. What we're going to add is like a similar like a tab parameters for this. Let's say like now for onco, we're going to have another tab that with these assumptions, because the population things are going to be constant, or like, the wages, all those things are fairly constant, but these assumptions are going to vary based on the disease that someone is talking about. So we'll add additional tabs that just deal with assumptions of various diseases, but then try to maintain like the other back-end issues as constant. So when you choose a disease, then it goes into the correct like tab and gets like the correct like values and calibrates those based on like the population of the district and all those things, and then you get like the output that you need. So I don't know if that's helpful.
Thank you, Walter. Yes, and I think maybe, Justin, again, if I can put you on the spot as well, and maybe Link, if you can share a little bit more about how the Act End NTDs West program is thinking about resource mobilization and advocacy, how that is being integrated into some of our work, so that all individuals understand, to Walter's point, that this model is not intended purely for publication, but for really being a very practical, usable, helpful tool for countries to mobilize domestic resources. So, and make the case for NTDs. So Justin, is there anything you would like to add as far as how the Act End NTDs project is planning to engage with this tool, or any of the background about how this will be used for resource mobilization?
Thank you, Courtney. I'm just insisting on what Walter said earlier, that the key point for this tool was to have something that is usable at country level. So strengthening NTDP capacity or local national stakeholders to be able to make the case, to build argument also, and also to assess scenario, trying to build different scenario on investing versus not investing on this area or not. So this option of building capacity at country level and making the tool something that is not very complex and complicated, but something that is effective in terms of messaging is very important, because for us, the long-term sustainability of what we are doing is based on the capacity of the national stakeholders and the system. That's one point. Another point for activists, which is very, very important, and this is an area where we are focusing a lot under the health system strengthening work. And the team also, we are coordinating with Deloitte, World Vision, HKI, and FHI also, is about looking to the advantage and then sometimes non-tangible also aspect we are having on this system, and what the health system is gaining. Valser really did it a few minutes ago, looking to the aspect of the time we are saving. How we can communicate to government the gain for the health system if we reach elimination, and how many hours we can save for nurses to dedicate time to something else. In a country where we are losing 10,000 CDDs for MDA. We are using numbers of nurses and teachers for MDA. When we reach elimination, I think there is a gain for the entire system to avoid reinfection, because going through reinfection is also increasing the rate, and using time people can allocate to something else through an MDA on some situation. So this is a real gain, I think, for the entire system, education system. It's a real gain for the health system also, and a real gain also for community workers who can dedicate time to something different. So I'm looking to that tool, and for Activist, it's not just standalone, it's a pilot. We are trying to refine the model here and have something effective. We can benefit for other countries, but this could be something that can be benefit for the entire community and all countries, and different settings also. So it's a critical aspect for us having a capacity at country level to make the case, to have argument, and especially in some of the country, West Africa, where we're having this shift of traditional budgets to program related budget, where you need a rationale for the Ministry of Health to decide where to put the money. You will need a rationale also for the Ministry of Finance to show the impact of investing in these areas and versus other areas. So that's what I wanted to bring here in terms of perspective for our West, which for these two, and where the resource mobilization, domestic resource mobilization fit in our approach in terms of sustaining the gain, in terms of avoiding reinfection once we get into the control of some of the disease or the elimination of some disease. This is very critical. It has been a very long investment, 10, 20 years in the country at that level. So once you get there, it's important also to take over the situation and avoid going back.
Thank you, Justin. Appreciate that broader context of the applicability, as Mary did in her presentation, of really telling the human side of the story of where we're trying to go with this tool, who really is intended to benefit from the outcomes. So I have a couple of questions coming through from Diana around the timeline, and then similarly questions kind of around the bibliography slide that was really showing around the literature that was reviewed. So Anna Maria, if I could first turn to you to see if you can speak briefly about this question saying, from Diana saying, assuming that development and piloting work continues again soon, how long before this model for LF will be ready for release? And then if you can also speak to, and I'm sorry, I'm now forgetting where the question came from, but to see if you can also speak to kind of what literature was reviewed in the development of the tool as well.
So on the timeline, assuming that we don't face further delays related to, we have been facing some delays related to the COVID-19 pandemic. So as you know, assuming we don't face further delays, we expect that we'll have a tool that's ready to pilot by the early fall. And then we'll be able to pilot that with our Sierra Leone NTD program colleagues in the Ministry of Health and Sanitation. And then we'll be refining it and aim to be able to use the tool, the LF tool specifically with other countries in the calendar year of 2021. And so that's our ideal timeline right now, assuming that there aren't other delays. And we hope that the next few months we're able to really refine the tool through piloting with the NTD program in Sierra Leone. As far as literature, I'm going to have Walter kind of walk through the literature review that we've done. But overall, I think this, if you go to the slide on references, we spent the first several months of development reviewing literature around NTDs and around any investment cases that have been made and assumptions around NTDs. And so I'll have Walter kind of walk through some of the key literature that we've used in building out the model.
Oh, I think that's a screenshot of like the papers we looked at, but there have been lots of of articles, and it's been pretty much iterative. So, for example, looking at like different utilities, we've used like multiple sources, you know, from like Institute of Health Metrics and Evaluation into like published work. We've looked at like, so the challenge that we had is, you know, if you didn't get like, let's say some utilities for a particular condition somewhere, then you just look for the next available paper. And it's always, it's more of an art form at times, like to get some of these inputs. And I just don't know how to answer that question. Like it's really hard. This is just a screenshot of the things we've looked at. But if you look at the tool, you're going to see like at different tabs, you will put like the citations of like, we got this value from this particular paper. We got a different tab, we got this value from a particular paper. So this is just a screenshot. It's not like the entire universe of like the things, the papers that we reviewed in making the tool. And plus, of course, we use like Mary Hodges' excessive experience in calibrating some of these things too.
Great, thank you, Walter and Anna Maria. There's a question about whether this can be applied to the, this model could be applied to the subnational level from Joyce. I guess Mary or Walter, is that, or I think any of you could probably shed some light on that, but if you could provide a little bit of context for that question.
I think the answer is yes, and it's very much dependent upon the size of your country. As many of you know, Sierra Leone is a small country with just around 8 million people. So we've developed a tool that works at national level and to some extent would work at sub-district level. But obviously, if you compare Sierra Leone with Nigeria, where one state may be several times the size of Sierra Leone, looking at sub-district level data will be far more important and a lot more work for Walter and his colleagues.
And one thing I'll note, you know, the economic impact model does pull from the TIPAC, and the TIPAC breaks down data down to the subnational level. And so if the users have the data at the subnational level and they're able to enter that into the TIPAC or into the economic impact model, then the model itself will be able to calculate it at the subnational level. So it really does depend on the availability of data, but the model itself can accommodate that.
Great. And so here's another question, and Walter, I'll turn to you first, from Stephanie asking, how are you dealing with costing MMDP to programs where adequate care may not be currently provided? She gives the examples of current expenditures too low or inadequate. So Walter, is that something that you can respond to? And then I'll open it up to Mary or Anna Maria if you have additions.
Sorry, could you just repeat the question again? Sure. I would like this funding?
How are you dealing with costing MMDP to programs where adequate care may not be provided currently?
Adequate care may not be provided currently. I don't think we thought about that, like adequate care. I don't think we've really thought about that.
Again, I think we come back to TIPAC, and when TIPAC was being populated, the national program often overlooked some of the major gaps in funding. Since they were such major gaps, they were really not on the horizon of thinking, and mobility management was one of those major gaps. And it was only when you started saying, well, hold on a minute, if we really want to get to LF elimination, we have to cover this gap. We know at present it's either non-existent or inadequate. What would it cost to actually make it exist and be adequate? So again, we need to populate the TIPAC and find out what that economic gap is before the model can do its magic.
Thank you, Mary and Walter. There is an additional question that just came through that I think is important to address, and that is, it's really thinking about that this is from Diana, saying that this is a very technical, of course, this model is technical. So once it is piloted, how can more less technical users utilize this model? What are we doing to make sure that this is not something that you need to be a health economist like Walter to be able to utilize? And then who would be the optimal user to present the results of the model to government? So for that first question around just the employing the usability, and then the presentation actually as well. Anna Maria, if you could start with your response, and then I'll open it up to Mary and Walter as well.
Great question, Diana. This is something that we thought, we have been thinking a lot about as we develop the model itself and the tool. So from a user perspective, what we really tried to do was simplify the data entry elements such that a user would be able to access this, a user in the NTD program would be able to access the data. And it really captures, you know, the costing elements that an NTD program would have access to, as well as incidence data and other data that's related to the country and the NTD prevalence within that country. So that is within the NTD program's ability to access. And so we really focused on making sure that it's, from a data entry perspective, easy for them to take that information that they have and very simply put it into the back end of the tool. And then in the front end of the tool, where it's the dashboard, which I think Walter shared before, we really tried to use layperson terminology throughout. So, you know, when you really look at the dashboard, it's what's the economic return on investment at the national level, at the district level? What are the cost savings for out-of-pocket expenses for a household? And it really puts it in terms that are simpler. Yes, there are more technical terms in there, but depending on, you know, what the user is looking for and who they're seeking to engage, there's very simple terminology, layperson terminology, so that a user can look at the results of the tool or of the model and be able to extract the information they're looking for. And we're spending a lot of time thinking through how to make that an easy interpretation of results. And then as we pilot it, we're also going to be asking our end users, the NTD program, to be giving us feedback on what is not clear, what is clear, how do you interpret this, how, you know, how can this be more easily interpreted from their perspective? So that's where the piloting will be really critical. But throughout the development, we've really been thinking about how could a user, a non-technical user, potentially use this and translate the results appropriately. As far as who's to present the results, you know, it's we're thinking about what's the purpose of this is to enable an NTD program to make an investment case and advocate with stakeholders as appropriate domestically. And those stakeholders can range from the Ministry of Health to the Ministry of Finance to the Parliament to even private sector players. And so depending on who they're seeking to engage, what messages resonate with them, what information those stakeholders may care about, the NTD program will be able to go into the tool, create an investment case based on these kind of key questions that they're hearing a lot of from different stakeholders. And depending on the level of engagement, you know, it might be the director of the NTD program who needs to make the presentation. It might be, you know, if they're at the district level, it might be someone who's within the national program who's not the director, or someone who supports the program, the NTD focal point, for example, at the NTD, at the district level. It depends on the level of the stakeholder, the level of engagement. In many cases, it may be the director of the NTD program if we're talking about national level engagement. But again, it will vary depending on the stakeholder and the message that needs to be, or that they seek to articulate to that stakeholder. Mary, is there anything you want to add there?
Yeah, I think part and parcel of what we've been doing with HKI and Deloitte over the last 6 months, and certainly since COVID stopped any chance of international travel to Sierra Leone, has been the remote training that you have led with the national program and with Helen Keller in building capacity of our colleagues and ourselves to be able to populate the data required in TIPAC. And I think that capacity building, which was mentioned in my set of slides, is an ongoing process. There will be a lot required to really build the capacity so people know what data to enter and they know how to interpret the data that they get back and how to recognize that that data may or may not actually hit the nail on the head and whether the assumptions need to be modified. I think that's going to be a work in progress for some time yet.
And then Courtney, I know to Diana's question, I think it was based on that slide that you put up, that the one that had like different parameters.
Mm-hmm.
Our point was that the normal user is not going to change those parameters, like those distributions at all. But if someone felt, a more advanced user felt that they want to change the assumption, they could. But at the back end, they're not really going to change those parameters unless you really felt like, okay, let me play around with those distributions. So just to clarify that aspect, like the tool is meant to be extremely simple to use. The more technical bits around distributions or, like probabilities will not be changed by the everyday use of the tool.
Thank you, Walter, Mary, and Anna Maria. So I'm going to combine a couple of questions for a final question before we close. So this is around similar to when we talked about before about scaling this to the other countries and how technical do you need to be. There is a couple of points around just the training to users, the capacity building, so that others can use the tool, even if it's more simplistic, wanting to make sure that there's a usability of a tool like this across a range of individuals in different countries. And so there is a question around both how the training and the user guide will be developed and unfolded. Anna Maria, if I can turn to you first to answer some of those questions, and then we'll open it up to our other speakers here.
Great. So the user manual and training is something that as part of our roles, Deloitte will be developing in collaboration with the CDC and HKI, and then piloting it in Sierra Leone. So there will be a user guide that is available that is accompanying the tool itself, and the Deloitte will be developing that. And then as far as the training will reflect kind of the user manual and how to go about using it and how to go about entering data into the economic impact model, and more importantly, how to go about translating the outputs or the results of the model into an investment case, and how you might target some of these investment cases in advocacy with different stakeholders. So the training will really focus on the entry, but more importantly, the interpretation and use of the results that are outputs of the tool.
Thank you. And Walter or Mary, anything else that you'd like to add about just how we're going to engage a broader audience in being able to use this tool?
I think the pilot in Sierra Leone will be a worthwhile experience, which will have to be repeated in other countries, and the capacity building in other countries will have to be repeated. And as I said before, we have been delayed and frustrated by COVID, and the effort that our national program colleagues are having to put into the COVID response has really limited the amount of time and attention they've been able to spend on this tool. And I'm sure that's the situation everywhere in Africa. But we hope as soon as COVID is behind us, we'll be able to refocus and get back to NTDs and to this economic impact model and really get everybody's attention back on it and bring it to fruition and make it a useful tool for everyone concerned. I think it's really important. For me, the starting point was the technical people were banging on about the technical benefits of NTD programs, and the economics people were not understanding what we were talking about. And I really hope that this tool will bridge that gap and be able to make us communicate more effectively with the people who control domestic financial resources.
Thank you, Mary. That is an excellent note to end on. I think that is a wonderful summary of what we're hoping to get out of this, this model. So I want to first thank each of our speakers, presenters here today, Mary, Walter, and Anna Maria. I really appreciate your participation and leadership here. I'm always very pleased to see, as I've been trying to monitor the chat box, that along with questions, there were a lot of follow-up points and shared contacts. So really looking forward to hearing from many of you so that we can continue this discussion. As has pointed out, this is a work in progress. And so for those who have additional ideas, want to continue the conversation, have any suggestions of further models or shared resources, really looking forward to hearing from that. And then thank you all for your participation today and all your questions. I hope we answered most of them. I apologize for not getting to all of the questions. But again, please feel free to follow up and continue this conversation once again. So thank you, everyone, and enjoy the rest of the conference.
Thank you.
Thank you.
Thank you all.